Howdy, everyone. Matt here. I got a question for you. What do you think about orthopedic special tests? Do you think they're these great, wonderful, amazing things, or they ain't worth a hill of beans? Let's talk about that. First and foremost, let me introduce myself. My name is Matt the PT, coming at you with another video on another topic of something in the physical therapy world. That one is orthopedic special tests. Now, I know some of y'all are going to start going there, well, special tests aren't special. They're not, blah, 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 all that. And I'm going to tell you this right now. I like orthopedic special tests. Now, again, you're probably about to start bashing me, hold off on throwing your tomatoes just quite yet. But let me bring this up. One of my favorite sports to watch, and I'm going to use this analogy, is football. My teams, Mississippi State Bulldogs for college, and in the pros, the Chicago Bears. Now, are either one of these teams winning Super Bowls or national titles? No. Are either one of them winning conference titles? That's also a no. Are they winning division titles? Okay, stop. They're not winning either one of them. We're sometimes lucky to get above 500. But I still like both teams, and I will still cheer for both teams. And I feel you can do that with orthopedic special tests, that you can like them, but at the same time, understand, sometimes they're not special. Sometimes they aren't valid. Sometimes they aren't reliable. Sometimes they're not worth doing. But like I said, I still think they're very interesting. And I just wanted to talk about it and share it. And of course, I want to hear your opinions and beliefs and all that down in the comments there. But I was going to share about some of the stuff that I really, really like about them, and just want to get that out there. First thing, I do see that an orthopedic special test is something that's cost effective, really, because you're coming in, because the patient is coming in with a pain or some kind of issue, and we're wanting to diagnose them. We want to have a diagnosis of what is going on with this patient so we can provide them the treatment. It is something that we can work with. Do we need to refer them over to someone else? Do they need surgery? Do they need any of that? And it's, like I said, cost effective because it's something that we can do, that they're sitting in front of us. They often don't take a lot of time. They just have to have you performing them, and you just interpret the results of what you found. You don't have to send them off. You don't need big fancy machines. You don't need any of that stuff, but you can get an idea pretty quickly of a possibility of something going on. Now, we can argue as well that, again, other things like MRIs and imaging and all those tests, they're not very good either, that there can be a lot of overlap with stuff. It can find abnormalities and it doesn't increase outcomes. And I'm gonna say all of that as well. But again, a lot of that stuff can cost a whole lot of money. Again, granted, even here in the U.S. with insurance and stuff, I tell people, I'm like, you can go for that MRI, but it may not tell us any more than, anything else. And there's probably going to be a comma in the price of when you go, and you just get a fancy picture. So there you go. I will also say that I do feel that orthopedic special tests are a way to build an alliance, that therapeutic alliance with a patient. I do feel that you can do that with a special test or with the testing. Now, there's that debate about, palpation and touching with patients. And that I've heard that since PT school, that, is it worth to put your hands on a patient? And I'm meaning that if you're a therapist working in healthcare, you understand what that means. If you're not, typically it's just like saying, hey, I'm coming in, my shoulder hurting, and, is the physician, the PT, whomever, they come in and actually touching the area. And I will tell you, I've went through different points in my career over, yes, it's good to palpate. No, it's not. Yes, it is. No, it's not. And I have really come to see that for many patients, they appreciate that their provider did that part of the examination. Now, again, we can argue as providers ourselves who are educated with the experience and the knowledge in the area to say that, sometimes palpation is not worth it, is not needed. But look at that from the patient's point of view. They don't have that knowledge. They don't have that experience. They don't have any of that training, any of that. They can think that, you need to touch the area that's hurting. You need to look at the area. And I cannot tell you how many patients that I've had who have been frustrated that they've seen one doctor, one specialist after the next, and just going back and forth. And they've said, nobody's ever even like touched it or even like looked at it. And to say like, okay, let me palpate it. Or patients, and I've had colleagues say this as well. They've had patients that said, you're the first person to actually even touch the area, to really look at it. And that's something I will incorporate into my evaluations now, just to say, oh, this is the area here. And it's just something easy and light that we're bonding with one another. And of course, I always ask, do you mind if I touch you? So I'm putting that out there. So, hey, do you mind if I touch the area, to get there? But with this special test, what are you doing? You're doing a little bit more investigating into the area. I'm coming in with my shoulder. You're just not like, oh, you're just asking a bunch of questions and, just checking off stuff on your iPad or just writing it. Hey, what? They moved me around. They did some stuff in there. And it could be like, okay, this person is investing in trying to figure out what is going on. And I will tell you this as well. I've had people that have come to me after going to seeing their doc, and they said, they got this diagnosis of rotator cuff tendonitis. I'm just going to use that. I said, how do they get to that? Did they move you around? Did they push you? Did they do anything? They're like, no, they just kind of like told me to raise my arm, and they said that hurt, and I said it hurt, and they just sent me here, and so it was this. So it's like, how did you get that diagnosis without really getting into it? And also, and I would say, in today's day and age, with search engines, social, things like that, it's really easy to look up a diagnosis. So if that provider just like, oh, this could be it, that person is going to go research it and sometimes try to do stuff on their own, and it may or may not be effective whatsoever. Now, I will say this is a bit of a drawback with special tests at times, is that from the provider side of it, so from our side, is that sometimes I don't believe that the test is done correctly. Now, if you've been subscribed to the channel, and I thank each and every one of you that subscribed, I've been putting out these special test videos here. Like I said, I enjoy them. I have been finding it very interesting to dive in and read the papers, and I try to go back as far as I can on these tests to those original papers to get an understanding of the why that the person was coming out. Because like I said, I like them. I find them very, very interesting. I find them interesting. And what I'm finding in reading it is how they are performed. And I can tell you, I've spent time shadowing physicians in the past. I've worked alongside other therapists. But I will notice at times that sometimes the test is not done in the correct manner. The patient's not in the proper position. They didn't stabilize something. They put too much force, not enough force. They let them with their questioning. And it's like, okay, did you get a good, is that the right answer because you didn't do the test correctly, And I've seen that maybe they just do it kind of sloppily, just like, okay, we just come up, like a Hawkins Kennedy. They just kind of threw them up and just, oh, okay, that didn't, okay. And then they just went about it. Or like a knee, let me just move you around real quick and just, did you really take them through it and, put them in the right position and stress those tissues correctly? There's another part of that this has been the big thing that anytime I've worked with students, that the questioning to the patient can be a little leading. The biggest thing I see, and I will tell every student this, that for many of the special tests, what's a positive? Pain. And that they will lead a patient with that line of questioning. That they put a Hawkins Kennedy, they put them up there and turn them in. Does that hurt? That's what you're going for. You're going for so you told the patient what you are wanting. And so the patient may or may say yes or may say no. And what what could be the rationale that they do either one of them? It could be, yeah, it does hurt. But I would argue, is it their same pain? Are you producing their same pain? Or are you just producing pain in general? Because again, some of these can be a fairly painful test. Is the patient being truthful with you? And I will say this, there's times when people are after a secondary gain, and if you are telling them, oh, is this painful? They can go, oh yeah, I could say it's painful, and it may lead to these other things. And that's not really going to provide them the best care, because it may lead to a misdiagnosis, or not treating things correctly. So with students, I tell them, don't lead. When you put somebody in this position or you do this, to ask them, what do you feel? And that's what I still do that now. If I put you here and I do this, what do you feel? And somebody may say like, yeah, that hurts. Okay. If it say it hurts, where? Because it could produce symptoms in a different area. It could produce a different quality of it. So you put them here as like, I'm having like a dull, achy pain on there. Excuse me, it's like I'm having a sharp pain, but if I do this, it's kind of like a dull pain. It's like, okay, I didn't, that shouldn't be, that's not the right positive. They're both a pain symptom. They're both an interpretation of pain, but, is this the right one? So with all that being said, I think there are a few things that we really, really need to understand with an orthopedic special test. So, of course, understanding like how to do the test is a very important to understand that we're setting somebody up, we're not leading them with what we're doing, but also keeping in mind that our evaluation is so key, that we understand the patient's history, that we understand what limitations that they have, what their pain symptoms are. And I think that's what helps with making the tests a little bit better. I also really believe that it's important to understand with many orthopedic issues is that there is overlap with so many conditions. And I remember this. So before I went to PT school, I had to take abnormal psychology. And it was a very super interesting class. And so getting into the diagnoses of these disorders, that there was it was so like I said, it was so interesting that if for these different things, it was like, okay, they have to have these hallmark symptoms, and you'll be like 5 of these hallmark symptoms plus 3 of these 5 secondary symptoms, or 4 of these 7. So as you see, it was like, okay, a lot of these kind of act like one another, but there's just a few little key things that differentiate each one of them. And I really think that's what we need to understand when we are using some of these tests, is that a patient could come in, we'll say, with a shoulder that's very inflamed. And is it going to be an accurate diagnosis if we use like a Hawkins-Kennedy test to say, oh, it's impinged? Well, this person's really inflamed, and so that may not be an accurate test. But if we look back through the history on everything they're telling, to say, okay, sounds like more like this person is just in an inflamed state, we need to let it calm down, that we're really kind of understanding the whole thing with using the test. And, and then using clusters of them. So like, I also think that the clusters of tests are good too. It's like, hey, I'm going to do several of them that kind of test this versus this. And, it may lead more over toward this diagnosis. Now, I'm going to say as well, it doesn't mean that you have to be 100% to be like, yep, that's it, because this, but it's like, no, because, and this is a big one too, and this, I'll kind of wrap it up with this point, that I really like to use tests, these special tests, as a test retest. So that if you come in day 1 and I test you with this, and we do this treatment, and then we go back and try that test again, and you say, oh, well, that doesn't hurt now. That's going to give me something to say, okay, maybe it's not this, or maybe this is what you're doing is helping you now. And so I do see that you can utilize these, again, cost effective, that you can see, are we getting a change? Maybe my thought process, or maybe what I thought it was at one point changed because the tests are different at different points. So I think that's where they can really fit there. So, of course, get your good history, do you a good assessment. If you want to throw those special tests in there to build that rapport, get that patient buying into you, you can, and maybe use them as a test retest. Like I said, that's how I utilize them. That's what I think about them. So with that being said, I hope you enjoyed the video. And if you did, please hit that thumbs up button. If you have a belief, an opinion, or whatever it is, share it down in the comments below. I would love to hear that about the special test. Do you have any of them that you love? Do you have some that you hate? Let me know down there as well. And, of course, consider subscribing to the channel. It won't cost you a copay, anything like that. And, like always, take care of yourself. Take care of your patients. I will see you next time.